Jason. I'm just going to do an audio check, make sure you can hear me okay. Just thumbs up for Kelsey. There we go. Thanks, Kelsey. So thank you for joining over your lunch. This is not a heavy topic. It's more of interest. Want to get people thinking and really trying to demonstrate what we're doing at a provincial level here in Saskatchewan on opioid stewardship. So thanks again for joining and exploring our strategies. Opioid stewardship started as a program in 2020. We are a program with provincial scope, and we're always happy to engage with partners around the province, so never hesitate to reach out. My name is Leland Sommer. I'm a nurse practitioner in the program. I have been here, all said, probably about almost a year and a half, and I work with an outstanding team, and this has definitely been a team sport right from the start. So I am presenting from Regina, so within Treaty 4. The Saskatchewan Health Authority works in the spirit of truth and reconciliation, acknowledging Saskatchewan as the traditional territory of First Nations and Métis people. Please consider where you're attending from and consider your truths. I acknowledge the colonial and racist participatory harms of the nursing profession, and I commit to being a reflective, active bystander who models safe, competent, compassionate, and ethical and trauma-informed care in all interactions. So the objectives for today are really to understand what was the problem we identified, what had been tried, what had we tried and failed, and that's part of learning is failure and making mistakes, and we're still making mistakes and we're still learning, and what had been tried elsewhere that maybe we could implement or try, uncover what did we uncover and how did we decide to move forward, what are we learning from that move forward decision, and then where do we want to take this? What are the next steps that we want to take? How else could this be applied? And that's really where I want to get your creativity going in what other ways can a similar approach be applied. So these are the foundational principles of opioid stewardship, is really to improve that opioid prescribing practice within the SHA, utilize non-opioid pain management strategies, and really reduce the patient risks with opioid therapy, such as dependency, overdose, and misuse. Another term is ongoing opioid utilization, say after surgery, so anything past that immediate surgical. For somebody that's opioid naive, we want to reduce that ongoing opioid utilization. So these foundations are really the basis for every decision we make, every action we take. We were recently published in the Ideas and Innovation section of the Journal of Opioid Management. So what I'm PAR-ting with old ways is really building on our PAR tool, or the Pharmaceutical Automated Reporting tool that we've developed. This is the foundation of the data that helps drive our decisions and our actions on a daily basis, and it also helps us measure actions that have been, interventions have been taken, and what impact are they having. So today we're outlining the basis of this publication and expanding on what we are doing in our daily work. I've included the QR code there if you're interested in reading it. It's not a long read. A lot of what I'm talking about today builds from this. There's just an easy way to get to that article if you happen to want to read it. So the problem we faced right off the start from 2020 is we really didn't have a defined objective measure of how are opioids being prescribed, how are opioids being utilized, what areas are using more or less opioids, how are order sets created, the policies and the procedures, what's the evidence behind that, what are the ordering trends, what's happening in a facility compared to another facility, networks that are separated, what's happening in facilities in the same network, or units or service lines. So service line being like cardiology or orthopedic surgery or general medicine. How are those prescribing patterns Are they different? Are they the same? What's happening on average? So that is kind of that small area variation. What is influencing those prescribing patterns in said location or unit or service line? And we had an overflow of information. That's why this person's face is getting blown off by all the papers. But it's also, we had limited resources. So we really, really wanted something that was going to help guide our resource utilization. We have a finite number of human resources and technical resources to be able to carry anything forward. So we had tried manual chart reviews, we tried the consultation service, and we did manual data extraction and review. So from July 2020 until December 2023, we did actually engage in reviewing about 1,900 patient contacts created through manual data extraction and chosen reviews from that extraction. So it was just I'm going to look at this list. Oh, this looks interesting. We're going to go look at that. That data extraction was the BDM data. So pharmacists will know BDM is the pharmaceutical database of every order written in the Regina area and across the province. Every facility, every hospital utilizes BDM to capture the pharmaceutical, the medication ordering, including the dose, the duration, the route, and the drug name, of course. So, and the frequency. So that was a rudimentary spreadsheet that then was manually reviewed and decisions made about who's going to get reviewed. The opioid pain consultation service operated from September 2022 until November 2023. That service received over 107 initial consultations with 210 follow-ups. This equates to about half a patient engagement per day over that time period. When we reviewed that, that project cycle, 75% of the consultations were from 3 surgical floors in the same facility. So it was pretty homogenous. We weren't really spreading our wings. We weren't able to kind of explore what's going on in many other places. So we identified that as a bit of a limitation. So this is where the conversation really started, and we wanted something automated and more proactive. We had manual charts. The existing system is manual charts, manual written orders, and the digital pharmaceutical database, which is BDM. BDM collects that pharmacy information and really can export it in usable forms such as an Excel spreadsheet. So we started looking. We started looking at what's in manuscripts, what's been done. We looked across the United States. We looked across Canada. Our partners in BC have really been doing some good work since before 2020. And so Thai et al., they have a manuscript implementation of an opioid stewardship program to promote safer opioid prescribing. And that's what really got us started thinking about the concept of a clinical decision support tool that integrates, we wanted to integrate opioid-related risk factors and that pharmaceutical information, the ordering patterns, to then give us something workable. So we tried and failed at the rudimentary Excel spreadsheet. So our next piece was, how do we get all this data organized and give it to us in a prioritized way to guide our work? We tried a basic spreadsheet, we tried to filter, we failed miserably. We knew there was a missing piece, and we very quickly figured out what that missing piece was when our department hired somebody, Paul, who's one of the authors on the paper, who is a computer scientist and programmer. And the missing piece was that talent, was that knowledge, and we are happy Paul has went on, he's teaching future computer scientists and programmers, and we have Khan, who now brings this skill set and continues to work within the PAR tool lots to update coding, make sure things are working properly. The value of that role in the stewardship activities is well documented in the literature across antimicrobial stewardship. And in opioid stewardship, the American Hospital Association actually really highlights that is one of your first steps. The first step is you need senior leadership, backing, and understanding of what you're trying to achieve. The number 2 priority is to have a computer scientist or computer programmer. So it's been well identified, that role in stewardship activities. The skills of the computer programmer are required to filter the BDM data, that pharmaceutical data, through the identified opioid-related risk factors, utilizing Python. It's a program language. I'm a clinician. I am fully able to admit, beyond me, but they simplified it for us. They put it through this language, and it spits out a report on an Excel spreadsheet that is actually usable and drives our daily work. The report lists patient visits with higher number of risk factors first, so it prioritizes them. Then the report can be further filtered, and I'm going to show you that in a few minutes. What we wanted to achieve had to be done with no additional funding or staff resources. We were really hoping for a system impact and utilize the motto, the least effort for the biggest impact to guide decisions. This motto controlled our decisions in times when choices had to be made. For example, when we're looking at opioid-related risk factors, there's a list of about 13 to 15. We narrowed that down to 9. And really, we use this motto saying, can we easily get dependable data from the opioid order data set for a particular risk factor or measure? Is that data going to have a big impact in comparison to the effort and the reliability of the data? So if it was going to take a lot of effort, a lot of filtering, and we weren't sure it was reliable, and it really wasn't going to have a big impact, we just stopped and went, we're not going to waste our time on this. We need to start somewhere. So that's really how we started to guide things to develop that clinical decision support system in the middle. So next I'm going to go through how we came about our list of opioid-related risk factors. So absence of naloxone order with an opioid order, really when we look at national guidance, North American guidance, if there's an opioid, there should be a naloxone order that accompanies that, because sometimes the processing of opioids can be unpredictable. Tylenol 3s, anything with codeine is a really good example. You have ultra-fast metabolizers, you have slow metabolizers. We don't know how somebody's going to metabolize that codeine until they actually take it. These are the characteristics or features of opioid therapy that elevate risk in opioid therapy. Risk factors can contribute to side effects, increased length of stay, ongoing opioid use, development of opioid use disorder, or opioid overdose. They are critical medications in pain management. We're not saying we shouldn't use opioids, but we need to give consideration to the risks of opioids. Again, we used that Thai article from Thai et al. From 2022, Woods from 2020, and Yang from 2023, along with a checklist developed by the Therapeutic Research Center for Opioids, or Therapeutic Research Center. They have an opioid stewardship checklist from 2020. That informed our foundations of what risk factors do we need to explore. And then we reviewed the data, reviewed how we would have to filter that. And these are the ones that we came up with that we felt were the least effort and had the biggest impact. Multiple opioids ordered, that really focused, like, do you have a Tylenol 3 on the orders, and a morphine IV and a hydromorph oral? That has been a common triad of opioid orders, which does elevate risk. I think many know the combination of benzodiazepines and opioids co-prescribed, that increased risk. Intravenous therapy, we have a policy within the SHA that intravenous IV routes don't get questioned within the 7 days. There's an exponential increase in the risk for continued opioid utilization with anything over 3 days for opioids. And there's research that backs that, a systematic review has backed that. IV is twice as potent at minimum and gives immediate impact upon administration. So immediate side effects and euphoria, depending on the opioid. So the risks actually climb quicker with continued intravenous route for the opioid medication. We, based on the current guidelines in Canada, we really looked at the MED taken or received over 90 in 24 hours. So MED is morphine equivalent dose. Opioid is the gold standard, so the tool actually automatically does the calculation. So if somebody is on hydromorphone oral, it takes that dose and times it by the calculating factor of 5 to come out to the morphine equivalent dose. So if somebody's taking 4 milligrams of hydromorphone orally, that's morphine equivalent to 20 milligrams. So not all opioids are equal. So this stratifies the data of thousands of patients' visits to help guide our daily work for the least effort with the biggest impact. There are limitations. The MED calculation, we did exclude patient-controlled analgesia, so the IVs, the parenteral fentanyl, so IV fentanyl, epidurals, intrathecal pumps, or cassettes, because we had no way of knowing digitally without doing chart reviews how much was actually received from any of those routes. So it was out of our control, and it was going to be one of those things where it was high effort and really didn't impact the outcomes. Naloxone usage is determined by removal from the Pyxis, or the automated medication cabinet. This is a limitation because we do know some units have their naloxone not in the Pyxis cabinet, so it isn't 100%. So this is an example of the pharmaceutical automated report when we first see it as clinicians. Across the top are your identifiers, the columns for the identifiers, and also the risk factors. You'll notice there's some columns in there that weren't on the risk factors. We've developed those based on feedback or program utilization, different areas going, this is interesting. Could you include identifying people that are possibly have an alcohol use disorder? So we developed a possible CUI use. We've incorporated possible opioid agonist therapy. There are equations that aren't perfect, but it gives us a good idea of that population coming through the hospital system, and really does inform us of people we may prioritize to go see if we can be of assistance and help the team and help the patient. On the left, normally there would be the visit number there, the facility number, and then the admit date, so we can kind of estimate how long they've been in. You'll see that it automatically calculates the MME taken over 24 hours, and also the morphine equivalent over the previous 24 hours. MME, MED, they are the same. It's just there's MMED, morphine equivalent dose per day, MEDD, sorry. They are the same equation, just different references. So in this tool, MME went in here. We more familiar on our public documents state MED. So one thing, on the right then, on the risk factors, you'll see where that circle is, it does list them by priority. So 5 meaning they have 5 true risk factors. So the initial intent was the more risk factors, the higher the risk. That is one piece of the pie. Where you see the circles on the left is we are actually filtering down because we want to go, okay, who's taking more than 90? Then we can go into the column MME taken, and we can filter to say 200 and greater. And that's typically where we're focusing right now on morphine equivalent taken greater than 200, and we're doing some work around IV over 7 days. Yeah, the opioid-related risk factors have been determined by systematic review for relevance, high impact, and low effort with the data. We're screening hundreds of visits a day, and then we're prioritizing our work based on what's coming back. So the PAR tool has evaluated or screened over 31,000 distinct patient visits in Regina between July 2023 and January 2025. This equates to 45.7 patients screened per day, and then we compare that to the 0.5 when we were doing a consultation service. So we've really increased our efficiency and our possibility for impact for patients and the system. We're getting to learn what's happening. We've also, with this, been able to increase our engagement. If you remember with the consultation, we were really geared towards 3 surgical units. We've been able to increase our engagement on the medical service lines by about 9% in the past few months by letting the data guide us where we likely need to be. So as we filter down, so this is an example where we filtered to somebody that was taking 600 morphine equivalent, and it's interesting. There's a couple of these where they're maxing out their opioids being taken. So there's another one where they're also maxing out. What's also interesting is we've filtered out those on opioid agonist therapy. So patient safety in relation to the opioid-related risk factors can be immediately assessed by filtering the data to reach a workable list of higher risk patients. For example, the circle patient is taking a high MME and maxing out what is available. The tool does not indicate they're on treatment for opioid use disorder. So we actually prioritize this patient, and we're going to work through what do we do for something like this. This is near real-time prospective data that drives the interventions and resource allocation, which is not something we typically have currently because we don't have an EMR or EHR in acute care. So this data is coming to us in Regina about every 72 hours. So we look at what's happening today, work our way backwards, and we make our priorities from that. The PAR tool provides organized access and summary to opioid-related order data and performs those MME calculations. This allows the opioid stewardship team to analyze what is contributing to risk. A work list of patients to be assessed by the team is created for daily work. The PAR tool, we've increased that engagement, and if you look, our top 5, and the naloxone, it's actually trending in a better direction. So the no naloxone with an opiate order, it still remains a high contributor, but it's actually trending in the right directions from some interventions we have implemented. The high frequency dosing, so that's taking an opioid every hour, 2 hours, 3 hours. Available MED over 200. We're focusing on that right now. So it is a fairly high contributor, and then the multiple opioids in the IV over 7 days. One unique piece that we deliberately and intentionally designed into this tool was equity. We engage in every patient interaction with trauma-informed approaches and motivational interviewing techniques. The data offers us the ability to identify and engage with patients living with or introduced to opioid-related risk factors every day. Approaching risk utilizing the PAR tool removes system limitations from the equation. The limitations could be practice, it could be knowledge, it could be discrimination, it could be racism, it could be a bias, or it could be a silenced voice. And that silenced voice could either be the team or the patients themselves. So this has really given us the ability to identify people living with risk that we don't have to depend on a referral. We can engage passively and see if we can support the team, see if we can support the patient. So this is an example of what the PAR tool retrospectively can do for us. So looking past data, the perspective data in the real time was indicating to us a driver was contributing to additive opioid-related risk factors within the orthopedic model line. The consultation service at the time had regular contact with orthopedic patients in consultation. On review of the postoperative order set and retrospective data, it was noted there were limited scheduled non-opioids, so something like Tylenol or ibuprofen. There was limited ordering of that scheduled. There might be a PRN Tylenol, but it wasn't scheduled. And multiple different opioid orders at the baseline. So that might be the IV morphine, the oral hydromorphone, and Tylenol with codeine, PRN. So those factors together additively contributed to opioid-related risk factors. We were engaged in an ongoing orthopedic model line project and offered feedback on the order set. We proposed prioritizing the pain management section based on systematic review, evidence, to order it from non-opioids to opioid therapies and limiting or providing one opioid option on that order set. The order set is the baseline. There is always an other section where the clinician can order something if it's not available on the order set. And we also recommended route-specific dosing because IV hydromorphone 2 milligrams is actually 20 milligrams morphine equivalent, whereas 2 milligrams oral is 10 milligrams. So your oral is half the strength of the IV dose, and there was a lot of challenge often stepping people down from IV to oral because we were trying to give them half the amount. And often they had pain, and then the IV dosing continued. Preliminary analysis, which is the chart here, shows, so the dotted red line is the date of intervention when the updated order set went into action, which was April 1st, 2024. So anything before that is on the old order set, and anything after that is on the new order set. Preliminary analysis shows an approximate 30% reduction in opioid-related risk factors for the population on the updated postoperative order set. We are currently analyzing post-intervention data to measure impact and inform the next PDSA cycle of the QI project. So we're going to look at specifics like opioid MED utilized, what's available, and all of those risk factors. So this really illustrates the tool drives our daily work, but it's also helping us measure our intervention. Going back to that patient, how do we do more? So going back to that patient taking the 600 milligram equivalent of morphine equivalent of oxycodone daily, the MORE tool is a clinical document to guide standardized assessment to confirm, assess, and identify opioid-related risk factors. So I've included the QR code. This is an approved SHA form. It's available to anyone in the SHA, and any clinician can do this. The instructions are actually included on the back. You can always reach out to us with any questions. This information guides the development of a treatment plan to optimize safer pain management, minimize opioid utilization, and decrease the risk of persistent opioid use or opioid use disorder. This was adapted with permission from Woods et al., and it's from the 2020 manuscript. It also includes predictors of fatal and non-fatal overdose after prescriptions of opioids for chronic pain, identified by Wang et al. In their meta-analysis and systematic review, which is a Canadian study. The Opioid Stewardship Program is available to clinicians across the province, and our contact information is actually on the form if you take a look at it. This is an example of a common treatment plan suggested for the information collected on the MORE tool, something that we might do, or we can, have a conversation with the team and guide some options for suggestions on decreasing opioid-related risk factors. Of the ones that we've done, we actually collect the data on that. 95.3% of our suggestions or recommendations from the MORE tool have been accepted by the MRP and the team. And our most common interventions would be around the frequency of the opioid, really trying to optimize those non-opioid scheduled analgesics, or adding new, adding the naloxone PRN, and changing IV-IM sub-Q to oral route if clinically appropriate. As we're moving forward, as we're collecting more data with time, we are now able to measure items across service lines. We are starting to identify trends, considering areas for implementation or intervention. This provides foundations for conversation of leadership and to guide information discovery and planning for intervention. So it's really, the data coming out of this is, it's new to us, and it is so interesting to see if our interventions have impact, if we're on one unit, if we're providing education, but also at a system level. It is going to be invaluable to us in the SHA, we hope. Similarly, we're able to look at units and trends, so we can kind of get a bird's eye view and go, we have 2 orthopedic units. It seems like different things are happening, but they use the same order set. So we can start to dig into that and why is that happening. This innovation connects directly with our SHA values and roadmap, enhancing safety and patient-centered care while improving efficiency of human resources by leveraging that data analytics to support decision-making. Because the BDM, so the pharmaceutical database, is a provincial database operated in all hospital pharmacies, the PAR tool is easily scalable and provides system-level data to guide opioid stewardship interventions. So really, we're in the phase where we want to scale up storage and data management infrastructure. So that is really looking at a SharePoint for the data as we move provincial, because our current, like within former RQ, it's harder to share information out. So we can secure things on a SharePoint, and it just makes it easier to engage teams and facilities in that. And then we want to scale out to hospital networks, hospitals and networks across the province. We also have our sights set on development of a dashboard to present this data and to disseminate the data to facilities, units, and service lines provincially, and integrate measurements based on the American Hospital Association Opioid Stewardship Measurement Implementation Guide. The SHA Opioid Stewardship team, we are really provincial, and I want to highlight our analysts and computer programmers. So we have Warren and we have Con, and then clinicians, we have a mix of nursing, social work, pharmacy. So we are diverse, and we really look forward to engaging with partners across the province. Here's our contact information. The QR code is our website. The website has the link to our library resource page if you're interested in reviewing that. And we always love a phone call or an email. And then these are the resources that I talked about that we've kind of based the foundation of what we're doing on. And please complete the short survey if you can. We always love feedback and want to know how we're doing. And I am open to questions.
All right. Thanks, Leland. I will stop the recording.